Hello, everyone. I'd like to welcome you to today's webinar hosted by Hep United, the Hepatitis B Foundation, and the National Association of County and City Health Officials. NACHO, Hep United, and the Hepatitis B Foundation are national organizations that work with stakeholders towards the prevention and elimination of hepatitis B. My name is Kate Morales, Senior Program Director with the Hepatitis B Foundation, and I will be your moderator today. Before we get started, I would like to take a moment to remind all participants that during today's webinar, you will be in a listen-only mode. And next slide, please. At any time during the presentation, you can enter questions into the Q&A box on the right-hand side of your screen, and questions will be addressed by the speakers at the conclusion of the presentation. If you have any technical challenges, please indicate your issue using the chat box. Just a little bit of background for today's webinar. Recent data indicates there's been an increase in the rate of new hepatitis B infections in the U.S. So to address this, we are excited to have presented a three-part webinar series on local strategies to eliminate the hepatitis B virus infections. Thank you for joining us today for part 3. This is the final installment of our series, Hidden Consequences, the Opioid Epidemic and Rising Hepatitis Rates. Today, we will explore the rising rates of acute hepatitis B infection across the U.S., discuss the impact of the opioid epidemic on increasing hepatitis infection rates, share local initiatives and challenges in addressing the epidemic, and identify best practices, tools, and other resources helpful to addressing hepatitis B in local communities. We have experienced since 2006, for the first time, the number of reported acute hepatitis B cases rising across the country. And we saw that in 2015 alone, there was nationally an increase of 20.7%. Next slide, please. Parts of the country hardest hit by the opioid epidemic are facing a rise in acute Hep B infection associated with injection drug use. And you can see here a map of acute hepatitis B rates by state. The rates are increasing from between a range of 62% in North Carolina, for example, to over 700% increase in the state of Maine. Next slide, please. Despite the availability of a highly effective hepatitis vaccine, barriers to preventing hepatitis B infection in the U.S. remain. These barriers include low rates of Hep B vaccination coverage among adults, combined with increased rates of injection drug use. It is critical to increase the Hep B vaccination rates, particularly among young adults who were born prior to 1991, when hepatitis B vaccination for infants became routine. While the vaccine series offers lifelong protection from infection, we can see here that data indicates that less than a quarter of all adults were covered by the 3-dose vaccine. And now I would like to move on to our two guest presenters representing 2 districts in the U.S. Our first presenter today is Jack Hildick-Smith, who is the Viral Hepatitis Prevention Coordinator with the Philadelphia Department of Public Health. He joined the hepatitis program at CDPH in 2017 after completing a fellowship with the CDC focused on hepatitis surveillance. As the Viral Hepatitis Coordinator and government co-chair of the Hep C Allies of Philadelphia, he has worked to increase awareness and testing of hepatitis in Philadelphia and expand community partnerships to coordinate existing hepatitis services and fill gaps in infrastructure for those living with and at risk for viral hepatitis. So I'll now turn it over to Jack to speak about a study led by the Philadelphia Department of Public Health in response to the rise in acute hepatitis cases.
Thanks, Kate. So I'm the Viral Hepatitis Prevention Coordinator for the City of Philadelphia, and I'm talking about what we named the Hepatitis Alphabet Study, and that was because we're trying to be a little cute about the fact that we were looking at serology for hepatitis A, B, C, and D all at the same time at a local syringe service program. And serology meaning we were looking at immunity as well as infection for all of those viruses. Next slide, please. So I just wanted to start off with a little bit of background data for the City of Philadelphia and what inspired this project. This graph is from our annual Division of Disease Control report, and it shows rates of acute hepatitis C in the City of Philadelphia. Those blue bars on the right show the number of cases each year, And the dashed lines show the cases per 100,000 in Philadelphia versus the United States. So you can see pretty clearly, starting in 2012, going to 2016, acute hepatitis C cases, number of cases were increasing pretty substantially each year. And if you look at the cases per 100,000, the Philadelphia line follows those increased cases, and the United States line does not really show as much movement, and that probably has something to do with the lack of surveillance infrastructure. But regardless, Philadelphia saw a pretty sudden increase in acute hepatitis C. Next slide. And when you break down these cases that we're seeing and the actual distribution of hepatitis C cases across the city, starting in 2007, you can see that most of the cases hover around people in their mid-40s to mid-50s, which are the baby boomer birth cohort. That's sort of the established disease burden. According to the CDC, according to all national statistics, hepatitis C is a disease of the baby boomers. But when we look at our disease surveillance data moving through time, first looking in 2011, you can see a little bump starts to appear over the mid to late 20-year-olds, so if anyone under 40 years old, and then going to 2013, suddenly this bump gets pretty sharp over the mid-20s, and by 2015, we have a bimodal distribution of hepatitis C cases in the city of Philadelphia, with about half being baby boomers and the other half expected to be people who are new cases that have contracted hepatitis C because of the opioid crisis, from injection drug use and other potential exposures from drug use. Next slide. So with this background and understanding that hepatitis C is increasing because of the opioid epidemic, we really wanted to get an idea of what was happening with the other hepatitis viruses. So these are hepatitis A and B rates from that same report. On the left, it's rates of hepatitis A in the city of Philadelphia, and on the right, it's rates of acute hepatitis B in Philadelphia versus the United States. So if you look at hepatitis A, just like the last graph, those blue bars are the rates of hepatitis A, and you can see going all the way back from 1998, and the red line is the doses of hepatitis A vaccine in the city of Philadelphia. And over time, you can see as the doses of Hep A vaccine increase, the cases per 100,000 of hepatitis A go down, and they stay pretty steadily down. Looking at acute hepatitis B, you can see the red dashed line in Philadelphia kind of steadily goes downward and stays pretty steady for a little while. And nationally, it's sort of the same. And then right around the end, like Kate was saying, there is actually an uptick in acute hepatitis B reporting. Next slide. So with this background, the Philadelphia Department of Public Health went into this project estimating that about 5% of the Philadelphia population has hepatitis A, B, C, and or D, and it's likely higher in people who inject drugs. At the time of this project, which was about a year and a half ago, the hepatitis A outbreaks that we were seeing across the country were just starting to spread. And so we were wondering, why wasn't this happening in Philly? And a little bit of a spoiler, actually 2 days ago, Pennsylvania announced a hepatitis A outbreak in the state. So that's a little kind of sad flash forward. Hepatitis B has similar routes of transmission to hepatitis C, so why are we not screening as aggressively for it in the face of the opioid crisis? We know Hep C rates are rising quickly, so we're really wondering, are we on the brink of an outbreak like other big cities, and have we had an over-reliance on past vaccination efforts for these vaccine-preventable hepatitis viruses? Next slide. What we wanted to gain by doing a study looking at the serology of all of these viruses is to understand, first of all, what are the infection rates like now in people who inject drugs at this highest risk group, as well as understanding how well protected they are with vaccine. We wanted to use it as an opportunity to educate this high-risk population about these viruses and how to prevent them, to link these people who might be infected into care and vaccinate other vulnerable individuals. We wanted to inform practice at syringe service programs and across the city in addiction service programs, and try and coordinate services with existing programs that are working to serve people living with hepatitis. Next slide. So how do we make it happen? I'm sure many of you working in public health and hepatitis are aware that there are pretty limited funds for any sort of intervention for hepatitis. Most states, or many states, don't even have baseline viral hepatitis surveillance infrastructure, let alone special projects budgets. So how did we make it happen? Well, what we lack in money, we make up for in social capital. We have many close partnerships, and we felt like this was sort of the moment that we needed to ask for help. We felt that there were enough overlapping programs and concerns that it was the time to see if we could all kind of band together and make something work. So we reached out to other programs in the Division of Disease Control and asked for supplies and volunteers and phlebotomists and phlebotomy materials. We talked to our lab to see if they could support us in our testing efforts. We reached out to Prevention Point Philadelphia, our local syringe service program, to ask if they were willing to have us and if they were willing to support us and if they even wanted this type of intervention to happen. And then we talked to the Hepatitis B Foundation, which fortunately for us is right outside the city of Philadelphia. So we have sort of the nation's experts right at our doorstep. And we were able to set up a partnership with them as well moving forward. So we had experts on our team. So it really kind of all came together as this group effort. And now with all of it primed, we use this as an opportunity during the planning, and I like to use it now as an opportunity, now that I have an audience for this, to talk about harm reduction and sensitivity when you're talking about or working with people who may use drugs. So harm reduction, for people that may not be familiar with the term, is just this concept that you don't have to fix everything at once, and you may not understand or know what someone else's health priorities are, but you can at least try and reduce the harm that's happening. So in a lot of cases, harm reduction means being able to provide syringes so that people, maybe they won't stop using drugs, they may not be ready for that, but at least they can do it in a safe way. And so we wanted to walk into this with a group of volunteers that understood that we were not there to tell people what outcomes we were expecting from them, but we were there to provide a service, and if people were ready to accept it, we could give it to them. Fully knowing that not everyone is going to want to be tested for a bunch of viruses that they don't understand, or get vaccinated for something that is not on their priority list, when really what they care about is getting housing or food. And this concept and this empathy is what was really at the core of this whole project. And we wanted to make sure that everyone going to work on site, to draw blood, to vaccinate people, knew that this was really our primary objective. And now, this is an audience that I can share that message with, because a lot of public health organizations may not be using that as their practice, and we don't want to alienate a community that has already been heavily alienated from the medical system. We're accessing this community because there is built trust, and we do not want to break that trust. Next slide, please. So with our supplies all in action, with our sort of tone setting complete and understanding we were going to a new site that was having us as a guest, we started training our staff on what the actual study would entail, what the step-by-step process was for recruiting clients, and getting supplies back to the lab, and what we were going to do about on-site training. And then we talked to the syringe service program to make sure that we were integrating a service and not just showing up and performing a study. We wanted to make sure that this study served two purposes, that we were understanding the community and also providing a free service to the community should they want it. And then we also tried to make sure that we were coordinating with the Hepatitis B Foundation with planning and staffing and referrals, because they were really excellent for helping us make sure we could handle the complex cases that we discovered. This little diagram here is just kind of a crude drawing of what prevention points overlay is. It actually has a few errors, but it gets the main point across that you come in the front. We were over in the exam rooms. We would recruit in that drop-in space and bring people back to one or two of the rooms that we were performing the blood draws, the surveys that were happening, and then providing a little bit of education for each patient that came in with us. That little TV screen is just to show that we were also providing an hourly education session on all of the hepatitis viruses for people that were just in the drop-in. We kind of took over the TV for a minute and showed our slides, which I'll show you in a minute. Next slide, please. So these are some of our recruiting and follow-up materials. We held up these posters just trying to spread this message. A lot of people may know about hepatitis C, but what about the other hepatitis viruses? We want to help our community. Please come get tested. We'll talk to you. We have a gift card, try and support each other. And then these little half cards were just reminding people that it's not a one and done situation. We have collected information from you. Please come back so we can bring it to you back once we have the results of these tests and try and link you to care. Next slide, please. These are the educational materials I was talking about. So on that little TV in the drop-in, we had a little slide deck for each hepatitis virus, really trying to cut through the details, but get to the important facts about each virus to try and empower people at the syringe service program. So just the basics of how do you get it, what does it do, or what does it look like, and how do you stop it for each virus. So you can see Hep A, Hepatitis B. If you can go to the next slide, please. I have Hep C, and then also Hepatitis D. So that was running hourly. Next slide. Now, the course of this study took about 4.5 months, and we recruited more than 400 people to be interviewed and attempted blood draws on all of them. We gave out gift cards for each person to sort of thank them for their time and encourage that they come back for their results. Unfortunately, we only got 384 successful blood draws, or not unfortunately, that's a lot of blood draws. It's pretty close to our goal, which was 400 blood draws. And so these are the outcomes of the prevalence of the hepatitis viruses. So I'll just run through them, knowing that the N was 384. For hepatitis A, we did not see any acute infections, though we did see one IgM positive. This was kind of confusing. We expected to see a lot because of the outbreaks that were happening, but at the same time, hepatitis A is an acute infection. It's very hard to catch it in the moment that it's happening, and a lot of people described their withdrawal symptoms as sort of overlapping with hepatitis A symptoms, so it was really hard to differentiate what was happening with hepatitis A. For hepatitis B, and this was a big one, we saw 7 current cases of hepatitis B, which is 1.8% of the population. We saw 77 passed or cleared infections, so that's 20.3% of the population had passed or cleared infections. And combined with the current infections, that is a pretty substantial amount of hepatitis B exposure. Because if you think about it, the passed or cleared infections, those are people that have encountered the virus in their body and have the serology indicators to show it. So that was pretty alarming to us that almost a quarter of the population had some sort of exposure to hepatitis B virus, and that was really what we were afraid was happening with the opioid epidemic. For hepatitis C, these are numbers that we were sort of expecting and we have measured in the past. There were 160 current infections for hepatitis C, that's 42.3%, with 46 passed or cleared infections and 19 passed or current infections where status is unknown. That means that we weren't able to get an RNA confirmatory test. So that's sort of 17 passed or cleared / unknowns that weren't confirmed as current infections. And lastly, hepatitis delta, we saw 4 past or present infections. However, In 3 of those, the hepatitis B infection had cleared. And for those of you that don't know so much about hepatitis delta, it can only replicate in the presence of hepatitis B. So we were sort of counting those as cleared infections where there was only one current co-infection for hepatitis B and D. Next slide, please. So taking a look at the immunity of hepatitis A and B, once again, the N is 384, we saw that 186 of the participants were susceptible to hepatitis A. That's 48.4% were susceptible. So only 51.6% were immune to hepatitis A, and that's either due to vaccine or past exposure. So we don't know that that's 51% were vaccinated. That means 51% are protected. We can't tell the difference with the serology results for that, but that's just sort of a bit of, we can't really tell, but we assume some of that has to be due to past exposure. Looking at hepatitis B, there were 148 cases that were susceptible to hepatitis B, so they were not protected. That's 40.9% are susceptible to hepatitis B. 153 were vaccinated, that's 42.3%, and 61 were immune due to past exposure. So together, that's 93 that are susceptible to both hepatitis A and B, which is 25.8%. So looking at that, that tells us that we are not doing enough to vaccinate our highest risk populations for hepatitis A and hepatitis B. Those rates for a recommended population should be higher. And also considering that a lot of these people are younger and may have fallen within the universal vaccination catch-up period, we would expect there to be more coverage. Next slide, please. So what did we learn? There was not necessarily as much current infection as expected, but there was a lot of past infection and exposure, which tells us that there is hepatitis circulating. There were a lot of people with risk factors who were not vaccinated. We need to be prioritizing these people that are at risk of exposure, and we're missing opportunities to protect high-risk people. And we can't assume that everyone is vaccinated. Next slide. Now, after we completed our study, we got all the results in, we tried to disseminate all of the results to patients and make sure that we were vaccinating susceptible participants against hepatitis A and B. We had a pretty thorough differentiation through our immunizations registry. And we were also offering hepatitis A and B vaccine to anyone that was in the syringe service program. We were just trying to make sure we also found the people that we tested. So it was open to everyone, even if you didn't participate. We also worked to link hepatitis B and C positive patients to care. Thanks to the Hepatitis B Foundation, we had specialized support and referral contacts. And hepatitis C, we are lucky enough that our local Hep C coalition has a navigation program that works out of Prevention Point, so we could give a direct handoff to the C Change program to get people linked to care. And then we tried to work with Prevention Point Philadelphia to reinstate independent vaccine capacity. That is has been pretty challenging. They are a heavily overwhelmed organization. We worked to get them a refrigerator and try and get things on par so that the immunizations program and our health department can provide vaccine for adults at risk. And that's sort of been an ongoing process, but we really think it's important. Next slide. And these were just our educational materials to make sure that people were coming to get vaccine. We put half cards in mailboxes with dates of our first clinic and had posters as well. Next slide. And we want to thank the organizations that supported us. Prevention Point Philadelphia was such a gracious host, and we loved working with them. It taught everyone at the health department a ton about what it means to work out in the community like that, especially in the peak of a crisis where they are the only sanctioned syringe service program in our city of 1.5 million people. We have to thank the Hepatitis B Foundation. They were incredible support and really the national experts. So we're so lucky to have them nearby. And the Department of Public Health, we had programs that had no need to support us, but they supported us through volunteers, and just because people care about what's going on in their public health, is really their passion. Next slide. And yeah, that's everything I got.
Thank you so much for that presentation, Jack. And I mentioned we will save questions for the end, but I see that some questions have come in through our chat box, and please do continue to send them along. And now I'd like to introduce our next speaker, Michelle McPherson, who is a nurse manager senior for LENOWISCO and Cumberland Plateau Health Districts, which is in far southwest Virginia. The districts serve a total population of about 203,000 individuals in Buchanan, Dickinson, Lee, Russell, Scott, Tazewell, and Wise counties, and the city of Norton. And now we will hear from Michelle, who will discuss LENOWISCO Health District experience with their acute hepatitis B outbreak and response.
Thanks, Kate. Good afternoon, everyone. I'll be speaking today about how the opioid epidemic has specifically affected rising hepatitis rates in the LENOWISCO Health District and the local community response planning and efforts that have led to the implementation of a comprehensive harm reduction program. As Kate mentioned, LENOWISCO Health District is made up of 4 localities: Lee County, Norton City, Wise County, and Scott County in far southwest Virginia, bordering the states of Kentucky and Tennessee. Much of our district is mountainous, as you see on the introductory slide. Next slide, please. LENOWISCO Health District, which is in the far left corner of Virginia, has been heavily impacted by the opioid epidemic and has experienced increases in injection drug use and rising rates of hepatitis and fatal drug overdoses. In 2017, in LENOWISCO Health District, prescription opioids and also methamphetamine continue to represent the majority of fatal drug overdoses. Oxycodone continued to be the most common prescription opioid causing or contributing to death. Next slide, please. As some background information, as you can see from these graphs, LENOWISCO's baseline rates of acute hepatitis B infection have been higher than the state of Virginia, with periodic higher peaks in those rates from 2010 through 2018. The rates of chronic hepatitis B infection closely mirror the state rate, although slightly lower. Next slide, please. Since 2011, the rates of both acute and chronic hepatitis C infection in LENOWISCO have been much higher than Virginia's rates. This is also true for Cumberland Plateau Health District. You'll see LENOWISCO represented by the blue line, Cumberland Plateau by the orange line, and the state of Virginia by the green line. Next slide, please. As you can see from this slide, in 2018, the rates of acute hepatitis B and acute hepatitis C are higher in both LENOWISCO and Cumberland Plateau Health Districts than both Virginia and the United States. The rates of chronic hepatitis C are also higher in both districts than the state. And also of interest in talking about the ongoing hepatitis A outbreak, Cumberland Plateau Health District has the highest rate of hepatitis A per 100,000 population right now in the entire state of Virginia. Next slide, please. As you can see from this table, the U.S. rates of acute hepatitis B have been on the decline since about the year 2000. Oops, sorry. I think my slides are out of order. Apologize. Let me go to this slide. For a 10-year period from 2000 to 2009, the LENOWISCO Health District has 17 cases of acute hepatitis B infection, meeting the CDC case definition for acute hepatitis B. From January 2010 through December 2015, the district identified 82 confirmed cases. To put this in perspective, during the same time period, the Commonwealth of Virginia had 486 cases, which means that LENOWISCO made up 16.9% of all acute hepatitis B cases in the state. So around 2012 is when LENOWISCO Health District began to see a significant increase in hepatitis B cases. Next slide, please. So on this table, you do see that the U.S. rates of acute hepatitis B have been on the decline since 2000. The Virginia rates have fluctuated somewhat, but generally decreased. However, LENOWISCO rates have risen dramatically from 2009 to 2015. At times, the rates have been significantly higher than other times, but definitely higher during that time period. Next slide. On May 1st, 2012, in regard to the hepatitis B outbreak investigation that began in our district, we received a report from a local hospital of an individual who was determined to be an acute hepatitis B case. She was interviewed by public health nurses but did not provide any contacts. Then on May 30th, the district received another report of an acute hepatitis B case from a different area hospital. During this case investigation, we identified 24 contacts. In turn, some of those contacts became case patients who revealed additional contacts. Next slide. As part of the investigation, the health district held 2 community health fairs in order to provide testing and vaccination services for participants. However, those health fairs were not very well attended. We found that the most effective technique involved multiple visits made to the homes of cases and contacts for testing, investigation, and education. During that time, we made presentations to local medical staff regarding disease recognition and prompt reporting. We offered rapid testing during a remote area medical event in that summer. We also evaluated infection control practices at a jail that was named by many cases and contacts during the investigation. It was discovered that a blood glucose monitor and Pinlet were shared among diabetic inmates. The health department later returned to provide educational training and establish appropriate infection control practices. Single-use lancets and individual blood glucose monitors were recommended. Next slide. So some tips for interviewing the cases and contacts and lessons that we learned were that it was very important to conduct in-person interviews. We just were able to obtain a lot more information once we established that face-to-face contact and rapport with the patient. Home visits worked well, or arranging a mutual meeting place. Most cases were reluctant to come to the health department due to fear or lack of transportation. It was important for us to be identified as healthcare providers, so our nurses would wear nursing scrubs and emphasize that we were healthcare providers, that our role was to assist them with protecting their health and the health of their family and friends. We also came to realize that it was important for us not to use a state vehicle or a leased organization vehicle to go to the homes, because many times that would be perceived as government workers, and it wasn't as easy to make contacts with patients. As we all know, sometimes people who use drugs may give inaccurate addresses or aliases, and so we found that we had to do a lot of asking around to try to locate cases. We did keep asking interview questions over again and in different ways. One thing that we learned in some of the education that we were doing with cases and contacts is that many times normal cleaning methods for their drug use equipment was unavailable because they might not have access to water or electricity or cleaning supplies. We also made a decision to always travel in pairs for safety reasons. We realized it was important to try to maintain contact with cases and their contacts. If not, then it would be very easy to lose contact and not be able to find them again. One important strategy that we came to implement was bringing food, water, or toiletries with us during the investigation in homes. Oftentimes, participants were very much in need of those things, and it helped to establish rapport, and it seemed to help the cases and contacts be more open during interviews. Next slide. So the results of the contact investigation in 2012, by April 9, 2013, we'd evaluated 177 persons. 125 of them completed testing. The remaining 52 were either unable to be located or declined testing. Based on the outbreak case definition, we identified 40 persons with acute infections, 6 chronic infections, 19 resolved, 23 immune by vaccination, 34 who were susceptible, and 3 who were indeterminate. Next slide. Just some more demographic information about the investigation. So 100% of cases were white, non-Hispanic, which relatively mirrors our population in our district. 70% were male. The mean age was 43. Also, in doing the hepatitis B investigation, we tested for hepatitis C and found 17 cases. All cases were HIV negative. And then when we made our rounds back to do some retesting of cases and contacts, we had 3 patients who were deceased, 5 had resolved their infection, and 5 more that were chronic. Next slide. So this is a comprehensive harm reduction wheel with clinical strategies that can be implemented for harm reduction. Since the hepatitis B outbreak in 2012, LENOWISCO Health District has gradually implemented all the components of the harm reduction wheel over time. So during the 2012 outbreak, we were using some of these strategies, but to date, we have been able to use all the strategies on the wheel. I'll talk a little more about that later in the presentation. Next slide. So as a result of the 2012 hepatitis B outbreak, the health department and LENOWISCO Health District made some decisions regarding some public health actions to take in response to that outbreak. So we began to offer and administer both HBIG and hepatitis B vaccine to contacts as medically indicated. We also provided educational brochures to cases regarding bloodborne pathogens, how to disinfect syringes, and what supplies that would be needed to do that. Case patients were able to receive follow-up testing if they so chose to do. And we also assisted them with referrals to primary care providers, in most cases to sliding scale clinics, in order for case patients to be followed more closely and to obtain treatment at that time. Next slide. One important educational brochure that was developed in partnership with the Virginia Department of Health was a brochure that explained the 3-cup method of disinfecting syringes. And we included that in the brochures that were distributed to cases and contacts. Next slide. This is a photo of risk reduction support supplies that were distributed by our public health nurses, our disease intervention specialists, and our EPI with support and funding from VDH so that patients would be able to clean their syringes. Next slide. I'm sure that many of you have heard about the HIV outbreak in Scott County, Indiana that began in late 2014. HIV infection spread rapidly among a network of persons who injected drugs in the small rural community of Austin in Scott County, Indiana. By the end of February, more than 40 new cases were identified, and by the end of 2017, 223 people have been diagnosed with HIV, and more than 90% were co-infected with hepatitis C. The conditions that led to the outbreak were not unique, but in response to the HIV outbreak in Scott County, Indiana, CDC conducted an assessment to identify counties that might be particularly vulnerable to the spread of hepatitis C and HIV among persons who inject drugs. Next slide. In April 2016, a regional tabletop exercise titled SwabX was held to plan for identifying an outbreak of hepatitis and HIV in the Southwest region of Virginia and responding to the outbreak. 4 Southwest Virginia health districts participated in the exercise. LENOWISCO Health District represented in orange, Cumberland Plateau Health District represented in the maroon pink color, Mount Rogers represented by purple, and New River represented by the teal color. Next slide. In November 2016, CDC published the county level vulnerability to rapid dissemination of HIV and HCV infection among persons who inject drugs. 220 counties were identified nationwide. In Southwest Virginia, 8 counties were identified, 6 of which are in LENOWISCO, and that includes Buchanan, Dickinson, Russell, Lee, Wise, and Tazewell. Next slide. In the wake of the HIV outbreak in Scott County, Indiana, and recognizing the ongoing vulnerability, in the fall of 2016, LENOWISCO Health District partnered with NACCHO and initiated efforts to develop a comprehensive community response plan for outbreaks of HIV and hepatitis among persons who inject drugs. The plan would serve as a roadmap to help departments to prepare for and respond to rapid increases in hepatitis and HIV among persons who inject drugs. Next slide. The components of the project would include planning and conducting a local tabletop exercise, drafting a community response plan, presenting the plan to stakeholders in town hall meetings, refining and republishing the plan, and future planning efforts. Next slide, please. LENOWISCO Health District held a second tabletop exercise, which built on the results of the first exercise. It expanded the scope to include hepatitis B and C as well as HIV, and it also included plans for ongoing sustained response. It engaged additional community partners and key stakeholders and focused specifically on the LENOWISCO Health District and Dickinson County and the Cumberland Plateau Health District. 69 participants from a variety of disciplines, community agencies and organizations, businesses, and individual community members participated in the exercise. The name of the exercise was HEART, and that stands for Hepatitis HIV Emergency Action Response Tabletop. Next slide. So information gathered during the exercise was used to inform the development of the draft community response plan. Next slide. The team understood that community engagement input was essential to the development of a strong, workable plan. Open town hall meetings were held in 4 localities on June 7th and June 28th, 2017. The primary focus of the meetings was to review key components of the plan and discuss ongoing efforts to address substance use disorder, viral hepatitis, and HIV. Background information was also provided to increase community awareness and knowledge of the infectious disease consequences of the opioid epidemic and harm reduction strategies to prevent complications associated with drug use. In total, 93 individuals attended the town hall meetings. Their feedback addressed the feasibility of the plan's components and provided general impressions for the response and recovery efforts, as well as addressing potential gaps and concerns. Next slide. The emergency response plan had 3 primary components: community prevention, community response, and community recovery. And the plan targeted education, prevention, surveillance and testing, partnering community-wide to provide education and training, also focusing on messaging and continued community status analysis. Next slide. In January 2017, LENOWISCO Health District became one of 2 VDH pilot sites in Virginia to offer PrEP, which is pre-exposure prophylaxis to prevent HIV, to at-risk patients, with funding made available through VDH Division of Disease Prevention. The PrEP program in Virginia has now expanded to include 17 health districts. Next slide. In July 2017, the Virginia General Assembly passed House Bill 2317, which authorized the Commissioner of Health to establish and operate local or regional comprehensive harm reduction programs during a declared public health emergency. This includes the provision of sterile and disposal of used hypodermic needles and syringes. The objectives of the program are to reduce the spread of HIV, viral hepatitis, and other bloodborne diseases in Virginia, to reduce the transmission of these diseases through needle stick injuries to law enforcement and other emergency personnel, and to provide information to individuals who inject drugs regarding addiction recovery treatment services. The programs would be located in at-risk communities in accordance with criteria established by the Department of Health. The bill required the Commissioner to establish standards and protocols for the program and required the Secretary of Health and Human Services and the Secretary of Public Safety to approve such standards and protocols. And you can see in the map, far southwest Virginia has several counties that were eligible to operate a syringe service program. Next slide. In September 2017, LENOWISCO Health District began to work with NACHO on Phase 2 of the Comprehensive Community Response Planning Project to engage local communities to build support for comprehensive harm reduction methods and programs. Next slide. Project activities centered around engaging and working with already established community coalitions for support, visiting an established syringe services program in a neighboring state to gather information and build upon lessons learned, and engaging the community at large through educational forums. LENOWISCO Health District has a close working relationship with the Appalachian Substance Abuse Coalition and has been able to successfully engage members around the concerns of bloodborne pathogen transmission through people who inject drugs. Employees with LENOWISCO Health District and members of partner organizations, including law enforcement, were able to travel to Charleston, West Virginia on January 31st, 2018 to tour the SSP program there, hear from program leaders there about lessons learned and best practices. From February 2018 to June 2018, employees of LENOWISCO Health District made several community presentations to local partners regarding the need for comprehensive harm reduction, including an SSP. In early June 2018, the district partnered with NACHO to bring a play titled Needlework for 2 performances, one in Wise and one in Clintwood. This unique play, an original play from Harlan County, Kentucky, portrayed community, taxidermy, wildflowers, sanctuary, drug addiction, family, and needle exchanges. After the play, members from LENOWISCO Health District and ASAC answered audience questions about comprehensive harm reduction and SSP. Next slide. LENOWISCO Health District then submitted an application in April 2018 to the Virginia Commissioner of Health to launch a syringe service program as part of a comprehensive harm reduction program. The application was approved, and LENOWISCO Health District opened the first SSP in the state of Virginia at the end of June 2018. The model used by the district is a one-stop shop model where participants may receive other healthcare services, talk with recovery coaches, and receive referrals for other services. There are currently 3 centers approved and operating in the state of Virginia, the one in Wise, one in Smith County, and one in Richmond. Next slide. This is an overview of the LENOWISCO Health District Comprehensive Harm Reduction Program. We started at the end of June 2018, and as of March 31st, 2019, we've had a total of 52 participants. The ages have ranged from 20 to 65, and we've had 349 total visits. An update to that, through last week, we have had a total of 83 participants in the program. Next slide. Some more outcomes of the program. Through the end of March, the program has distributed 7,033 sterile syringes and needles and have collected 8,860. It is a one-to-one syringe service exchange program. 42 individuals have completed screening tests for hepatitis C or HIV. 3 participants are participating in PrEP. 13 are currently participating in a hepatitis C treatment program. 3 participants are in recovery. 47 have received dual packs of Narcan to prevent opioid overdose, or to reverse opioid overdose. We have had 6 overdose reversals reported. 30 patients have been referred for family planning services, 5 for domestic violence support services. 1 pregnant participant has been linked with support services, and 25 participants have been linked with wraparound social services such as food, clothing, and housing assistance. Next slide. This is a photo of both our syringe exchange room as well as the counseling room where participants can meet with and talk to recovery coaches. Next slide. This is a photo of some of our supplies, our supply cabinet, and the harm reduction supplies that we distribute. Next slide. In July 2018, LENOWISCO Health District formed a new partnership with UVA Health System to provide telemedicine services to evaluate and enroll eligible clients in hepatitis C treatment. The district has 3 clinicians and 2 nurses that have almost completed training to sustain the program. So we've been very fortunate as we've had very limited resources in our area for hepatitis C treatment. And also with the expansion of Medicaid, more patients have been able to access treatment for hepatitis C, both in this program and outside the area. Next slide. So this is just a timeline that started from 2012 with the outbreak of hepatitis B all the way through the present and the implementation of the Comprehensive Harm Reduction Program in the SSP. Next slide. Thank you very much for your time.
Thank you so much, Michelle. And now we will begin our question and answer session. Just a reminder, if you'd like to ask a question, please feel free to send them by the chat box. And during the presentation, we did have a few that came in. The first question is for Jack. In the alphabet study, how much do you think your findings with exposure and susceptibility to Hep B is generalizable to the general population or other high-risk populations like Asian Americans and Pacific Islanders?
I feel like I have to be careful with that answer because I don't want to generalize on a very, small window study. We were looking at a very specific population at a syringe service program with, I can't remember the exact rate, but well over half of people who were actively using drugs. So I don't want to generalize about a population, but I think it's just a clear indicator of the potential outcomes of drug use for not just hepatitis C, but hepatitis B and A and D.
Sure. Yes, I understand. And I can supplement that a little bit. To the person who asked this question, we at the Hepatitis B Foundation work with partners around the country who have implemented community-based hepatitis B testing and vaccination programs. And not sure if it's generalizable, but it seems like the common percentage of susceptibles that we are seeing in various high-risk communities, particularly in Asian American and Pacific Islander communities, is around 20 to 25% who need the hepatitis B vaccine. All right, and our next question is also for Jack, and follow up to your presentation. How many people who were hepatitis B or hepatitis C positive were linked to medical care?
I don't have the exact number. I don't think we were actually tracking that, but the way it worked was for each case, if they had hepatitis B, we were pretty much immediately touching base with the hepatitis testing program at Prevention Point, as well as the Hepatitis B Foundation, to make sure that we were understanding the results properly before referring them to care. That was a little more challenging than hepatitis C, where every single case that was positive, we had the opportunity to walk them to the next room where there was a navigator for the C Change program that could engage them in care on the spot. So every single person that had Hep C that we were able to get back in contact with, they were directly taken to the C Change program. If we didn't see anyone that we had results for within the time frame that we were on site, we did a few rounds of phone calls as well, but those were not very effective because a lot of the phone numbers were not accurate that we had collected. So everyone that we contacted, we did our best to connect. I don't think we have like a specific percentage written down though.
Got it. Thank you. And this is for Michelle. In some of the Virginia materials, there was a phrase, prevention, not permission. Can you elaborate on the spirit behind this slogan?
Yes, I think I can. So in order to operate a syringe service program in Virginia, part of the requirement in order to be approved to operate a syringe service program was that you had to have the support of both local law enforcement and local government. And so, you know, I think there were some concerns in our rural, somewhat conservative communities that a syringe service program would be perceived as, I guess, as giving participants the idea that it was okay or that it was, you know, accepted for them to continue using drugs, when in reality, you know, the idea behind it is just to help them, you know, protect both their own health and the health of those friends and family members that they are around, as well as law enforcement and emergency personnel. So that slogan, prevention, not permission, I think was key in helping our community to understand the importance of comprehensive harm reduction.
Thank you. We have time for one or two more questions. Our next question is for Michelle. During the Hep B outbreak, did you first attempt contact by phone and then only attempt home visits for cases you couldn't reach by phone? Or did you arrange home visits by phone? Did you encounter any safety issues despite having 2 nurses at each visit?
So initially, you know, our routine way of conducting contact investigations is first to attempt to contact patients by phone. Many patients in our area may not have phones, or if they have phones, they may not have minutes on their phones, or their phone numbers change a lot, as do the places that they stay. So we found that to be a real challenge. And once we found that we were, you know, we had made some rapport in 2012 with some really key people in these communities, we were able, you know, they shared a lot of information with us. So when we did home visits, we would often be able to interview several cases or contacts at once. So we would oftentimes attempt to contact by phone first, but then found that doing home visits was just more effective. As far as safety issues go, we were very fortunate in that we did not encounter any safety issues. We did always travel in pairs, and we also implemented other measures, such as making sure that our staff let their supervisors know where they were going, the addresses they were going, the times they planned to be out, and when they planned to return. And if they didn't return by a certain time, they knew they were to contact us to let us know the reason for the delay. So all that worked very well.
Thank you. And then one last question for Jack. Can you talk a little bit about the vaccine series follow-up, where patients followed up to make sure they completed the series, or is this upcoming with the vaccine clinic that you had mentioned in July?
So that is a bit tricky. So what happened was, in the process of working with Prevention Point, the idea was to hold the first clinic to get people started, and once, while it was still fresh in their mind, and then get Prevention Point as a sort of remote vaccination site. We briefly had a period where they were allowed to be vaccinating, so ideally people would have come back for their follow-up doses in that time frame, but unfortunately there was sort of a lapse in the qualification for it's called the Vaccines for Adults at Risk program, and it's distributed through our health department. So they are no longer distributing vaccine, which means that people had to go to other sites or other VFAR sites, which is other Vaccines for Adults at Risk sites, to follow up. So unfortunately, I think our follow-up was not as good as we would have liked, though at least we were able to get people started on the vaccines. It was really tough to re-engage people. It was even tough to re-find people in the first place to initiate their vaccine series. But it was definitely a learning experience to see how tough it is to try and follow up with so many people.
Yeah, absolutely. Thank you. All right. We are out of time for questions, but if we were not able to get to your questions today, we will be sure to follow up directly with you via email or put together a Q&A doc and send it around to everyone. Before we close out, I wanted to share with you some resources that you can access for more information, including the NATO Hepatitis B Toolkit, additional fact sheets available at hepi.org, and please be sure to subscribe to our newsletters for continued updates and future webinars. And thank you for joining our 3-part webinar series. You can find those archived materials on our website, and we'll be sure to send updated links to today's recording and our past webinars as well in a follow-up email to everyone that registered and attended. And finally, I wanted to thanks to our speakers, Michelle McFerrin and Jack Hildick-Smith, and to everyone for participating in today's webinar. We hope that you found it informative and valuable to your work. And lastly, we'd like to invite you to complete an online evaluation to provide feedback about your participation in this webinar, and also feel free to suggest future webinar topics for us. And I wanted to recognize our NATO colleagues, Gretchen Weiss and Kim Sharp-Scott, who are also on the webinar today, and for their partnership. Thank you so much for joining, and please feel free to contact us at the contact information on your screen. And you may now disconnect. Have a great day, everyone.